Key components in planning, implementing, and monitoring a behavior change communication campaign that increased condom use among male clients of female sex workers in southern India. Today we will begin by discussing an overview of the condom use case study and its major goals, discuss social cognitive theory, its principles, and how its constructs align with the condom promotion program. Then we will discuss health behavior theory, its principles, and prove that health behavior theory better fits with the condom promotion program. There are 2.5 million people living in India with HIV/AIDS, which accounts for 10% of all people living with HIV/AIDS worldwide. The primary mode of transmission of HIV/AIDS is heterosexual commercial sex. This mainly affects 4 groups: sex workers, clients and partners of sex workers, men who have sex with other men, and injection drug users. Avahan Indian AIDS Initiative and the Bill and Melinda Gates Foundation provided funding for Population Services International to develop and implement a study to increase consistent condom use in heterosexual male commercial sex clients in southern India, and thereby decrease the incidence of HIV. The goals of the study were to increase condom use from 62% to 69% within the target audience, increase condom access, increase percentage of target areas meeting a minimum coverage standard for condom availability, and increasing condom demand by addressing behavioral determinants. To accomplish these goals, they align the study with 7 principles. Choose a defined behavioral determinants based on evidence, focus messages on one simple idea at a time, decentralize creative process and implementation management to ensure cultural relevance and scale, use several media and high frequencies of exposure to communicate the message, pretest all activities thoroughly, change themes every 4 to 6 months to reduce message fatigue, monitor activities biannually to measure, reach and recall, impacts, and determinants likely to have most impact as that changes occur over time. The study increased condom use incidence by 18% from May 2006 to May 2007. It focused on male clients of sex workers because they can bridge high-risk groups to the general population and, in encounters with sex workers, are often controlling the decision-making process regarding condom use. Activities within the study included questionnaires and interviews, condom demonstrations, street and theater and folk performances, and small group contests, games, and discussions. Next, we will discuss social cognitive theory. Social cognitive theory originated as a social learning theory and was developed by Albert Bandura. Social cognitive theory states that we are constantly interacting with both our social and physical environments. It states that we cannot fully explain behavior with external or internal factors, and this is because human behavior is complex and unpredictable. Social cognitive theory has multiple key constructs that we will discuss: reciprocal determinism, behavioral capability, outcome expectations, self-regulation, self-efficacy, observational learning, and reinforcements. Reciprocal determinism is a construct of social cognitive theory that states that behavior is influenced by personal and environmental factors that come from a variety of sources. It explains that behavior is a nonlinear process and is instead dynamic, influenced by multiple parts of our environment. Behavioral capability is a concept that explains that in order to perform a specific behavior, one needs to know how and what to do. For example, if I were to try to eat healthy, I would need to know what healthy foods are and how I should cook them. Outcome expectation is a person's attempt to maximize benefits and minimize the cost. If a person knows that there are a variety of outcomes, they place value on those outcomes and will perform the activity that benefits them the most while costing them the least. Self-regulation is a process in which a person endures a short-term negative outcome because they anticipate a long-term positive outcome. Self-regulation states that we can influence our own behavior through reward and environmental changes. There are 6 key management strategies to self-regulation: self-monitoring, goal setting, feedback, self-reward, self-instruction, and social supports. Observational learning is a construct of the social cognitive theory that human beings engage in naturally. This is learning how to perform a specific behavior by observing credible others performing the desired task. Reinforcements are incentive for motivation for a person to complete said behavior change. Reinforcement is modifying behavior through rewards or punishments for desired or undesired behavior. Positive reinforcement is a reward for a desired behavior. Negative reinforcement is a punishment for an undesired behavior. An example of negative reinforcement would be receiving a ticket for not wearing a seatbelt. Self-efficacy is the belief that you have the knowledge and skills to perform a certain behavior or action in the correct manner in order to achieve specific goals or outcomes. Self-efficacy is distinct from self-esteem in that you can have low self-esteem but maintain high self-efficacy. Methods for maintaining or improving self-efficacy include mastery experience, social modeling, improving physical and emotional states, and verbal persuasion. Next, we are going to discuss these constructs of the social cognitive theory within the condom use study. Reciprocal determinism is present within the study because we see the study planners using multiple levels of influence. These include group activities and demonstrations, theater and drama performances, as well as one-on-one instruction and interviews. Most of these activities influence a participant's social environment. They also influence the physical environment of the participants by providing condoms for their use. Behavioral capability is present in the study because they provide condom demonstrations to teach proper condom use to male clients of female sex workers. This gives them the knowledge and skills to use a condom efficaciously. Outcome expectations are present in the study because they attempt to prove to male clients of female sex workers that using a condom is efficacious and leads to a decrease in HIV incidence. They attempted to prove that the benefits of using a condom outweigh the risks of not using one. For example, within the study it could be said that they attempted to prove that although the clients may believe that they have a different sensation when using a condom, that quote-unquote risk is outweighed by the benefit of not contracting HIV/AIDS. When respondents participated in a communication activity, self-efficacy was evaluated with a questionnaire to determine the comprehension, relevance, believability, likability, persuasiveness, and gross negatives. They attempt to provide knowledge and skills so the male clients feel that they would be able to use a condom in a situation with a sex worker effectively to prevent HIV/AIDS and other infectious diseases. They provided social modeling and attempted to improve the emotional state of the male clients or their beliefs about condoms. They provide verbal persuasion through street theater plays and group activities. They provide a mastery experience through condom use demonstrations and other similar activities. Finally, they provide the social skills to navigate the situation with a female sex worker by exposing the male clients to similar situations to which they would be experiencing through street theater and folk performances. Observational learning is provided in the study with condom use demonstrations, street theater plays, and group activities. They attempt to teach the male clients how to operate a condom and how to use a condom or bring about the discussion of a condom in the context of a brothel or situation with a female sex worker. While it may seem that the social cognitive theory aligns with this case study, it is missing some key parts of the social cognitive theory. These include self-regulation and reinforcement. These are both goal-setting and reinforcement measures that come from the individual, and these would be difficult to gauge within this case study. It would only be possible to provide negative reinforcement through legal implications for not using a condom, or prove to the male clients of the sex workers that it was in fact the absence of a condom that caused them to develop HIV/AIDS or another sexually transmitted infection. Social support was not included within the case study as it was specifically chosen to be excluded. To include all areas of the social cognitive theory, it would be necessary to provide goal-setting and self-regulation activities that promote condom use within the study. The health belief model is another theory that I feel better evaluates the program. This is because it is based on cognitive processes such as thinking, beliefs, reasoning, and motivation. The program is specifically designed within the health belief model as well as one or two other theories. And the health belief model includes constructs extremely similar to those evaluated within the study. Next, we will discuss an overview of the health belief model. The health belief model consists of 6 constructs. These include Perceived susceptibility, or the belief about the risk of developing a condition, or the chances that one has to develop a specific condition. Perceived severity, or the perceived seriousness about the condition and its consequences. Perceived benefits, or the belief about the effectiveness of performing risk-reducing behaviors. Perceived barriers, or beliefs about the barriers that can prevent them from taking action. Cues to action, or factors that activate motivation to change. And self-efficacy, or confidence in one's ability to perform said action. Within the study, perceived severity can be found in that questions within the interviews and surveys given to male clients of the female sex workers included statements about their beliefs about the severity of HIV/AIDS or the severity of not using a condom. Next, they have evaluated perceived susceptibility because they have evaluated participants' beliefs about how susceptible they were to HIV/AIDS and how they felt a condom could affect this. Perceived benefits was evaluated because they evaluated beliefs about the benefits of wearing a condom both before and after the study. Perceived barriers were evaluated because they discussed social norms, beliefs of family and friends, and how that impacted survey participants. They also attempt to correct misinformation about HIV/AIDS and condom use, offer reassurance about condom use and HIV/AIDS, and assistance in learning how to use a condom. They provide cues to action with how-to demonstrations, promoting awareness about HIV/AIDS and condom use, and providing reinforcement through repetitive street plays in theater performances. And as we discussed previously, they also provide self-efficacy. Therefore, I believe the health belief model fits better with this program than the social cognitive theory, as two of the constructs of the social cognitive theory are missing from the condom use promotion program, and all of the constructs of the health belief model are included within the program.